My name is Mason Beard. I am a solution strategy leader here at Phillips Wellcentive. And our webinar topic today is going to be how one pediatric clinically integrated network align culture, technology, and the community to transform care. So just a couple logistical points about our webinar. Again, we're very pleased to have you. We're going to have about 30 minutes of content and questions, and then we're going to cut over to 15 minutes of question and answer. And if you look here at your GoToWebinar control panel, I'd invite everyone to look at their questions tab and type those in throughout the conversation so that we're ready to go when we hit that mark at 15 minutes. So I'm joined today by my co-host here in the Alpharetta, Georgia office, Gabe Orthos, who is a value-based care consultant with Hempformatics. And we have two colleagues who are joining us, Lisa Henderson, who is the Executive Director for Dayton Children's Health Partners, as well as Dr. Saeed, Associate CMO and Chief Medical Officer for Dayton Children's Health Partners. We're very happy to have them as content experts. So with that, I'd like to hand it over to Lisa to kick us off.
Thank you, Mason. Thank you for the introduction and for hosting us today. So we are excited for this opportunity to just tell our story and then connect with others on this notion of population health and pediatrics. I'd like to start with a brief introduction of Dayton Children's Hospital to set the scene for our CIN journey. Dayton Children's is a freestanding pediatric hospital in Southwest Ohio. We have 178 inpatient beds and had over 320,000 visits last year. And while we've had a strong history of taking care of kids in our 20-county region, we've really experienced unprecedented growth in the last 6 years, which have been exciting to be a part of. So we've opened a new 8-story patient tower in our main campus, a comprehensive ambulatory center in our South Market, and then have hired over 100 pediatric subspecialists, which those of you in pediatrics know is no small task. Tied to all this growth, though, is really a focus on innovating the path to children's health. So while all of these new physicians brought unique, high acuity programs to Dayton Children's that have really taken us to new places and taken care of sick kids, there's also a real focus on keeping kids healthy, which is where our CIN strategy comes in. So Dayton Children's Health Partners started about 3 years ago and has grown to include 12 practices and more than 125 independent primary care physicians, most of whom are pediatricians. It also includes 135 plus pediatric specialists who are a part of our network. Our primary care membership spans our 20-county region in terms of geography, but also varies in size from one-doc offices to multi-site practices. So we have what I like to call a small but mighty team that supports the network, including Dr. Saeed and myself. And then we have a clinical population health expert, a program manager who wears a ton of different hats, and a data guru, because everybody needs a data guru. So these stats cover the basics of our network, but we really look forward to talking more about how and why we got where we are today, because as you all know, no two networks are the same.
Great. Thank you, Lisa. That's great introduction into our conversation today. Dr. Saeed, if I may, I would like to ask you the first question here around what was the gap that led to the development of the clinical integrated network, and what were the challenges that you experienced?
Hello, everyone. Thank you, Gabe and Mason. We are happy to share our journey with the rest of the attendees on the webinar. Some of the things that sort of lent some urgency to our journey in developing our CIN was that it seemed the right thing to do for our hospital and for our community physicians and for our community and region. There has been a trend and move to value-based care, which has been much more pronounced in the adult world, but is gaining traction in the pediatric arena as well. Usually, pediatrics is behind the adult world in most initiatives, and we were learning the gaps in our unique market and wanted to be one of the early adapters in this move towards value-based care. Most of our community physicians are independent practitioners, and they owned by the hospital. So we really wanted to identify the relationship and the partnership aspect of this CIN, where the population health approach would help bridge the gap in outcomes and cost of care. Our focus was to have a partnership between the hospital and the community physicians, and we would wanted to base this partnership on the trust that was already existent in the community between the hospital and the community physicians. Lisa, do you want to add anything to that?
No, I think that's just a really, what you just pointed out is a really big part of it. So we had a lot of independent community physicians, but had a great relationship and really wanted to, continue to leverage that as we looked at our population health model.
So we actually converted the trust into a leveraging partnership tool and activity for improving the health and population of the region, children in the region.
So Dr. Saeed and Lisa, I've heard the word community several times as you're going through this presentation, and it's noted that it's not a kind of a hospital-centric viewpoint. And I was wondering, just on that note, had you determined that you wanted to involve the community, and kind of what did you think the significance of that? Because it seems like a novel approach.
The community involvement of the community physicians was just absolutely critical and was really our step number one. So as we talked about, whether or not we wanted to create a pediatric CIN, probably 3 or 4 years ago now, it really started with getting a group of independent physicians together and really talking about how we might be able to support their practices, work together on quality programming, and then continue to build relationships. Because as Dr. Saeed touched on, the model in healthcare has really changed. So these independent pediatricians are rounding at the hospital less, they're coming to the hospital less. So there was really an opportunity to also use our network as a way for independent pediatricians to work better with one another and to work with our subspecialists on quality programming. And that's where I think we've seen the most excitement from our physicians and really eager to engage on that networking.
Yeah, I would certainly agree with that. And what we have done is the engagement of the community physician is a foundational principle for us. And as we have seen and built upon, this has resulted in lots of networking opportunities and learning of best practices between practices who represent the CIN at the committee level. And that has been, I would say, a refreshing learning and experience for all involved in this network and partnership. It's a huge return on investment as far as I'm concerned.
So as I think back on there, so Lisa, for the clinically integrated networks that are just now forming, and looking back on your experience, Dr. Saeed's experience, what would you say was a critical first step, and what would be something that you maybe would advise a new CIN as they're looking at engaging the community? Clearly, this is a critical step, but what did you learn? What's best case practices, and what's the first step?
Well, I think I'll take the first step maybe. I think that what we did was really start with a group of community-based primary care physicians, along with some of our hospital-based specialists. But we really asked them to come together before we asked them to sign a participation agreement or any kind of contract, and really planned the model as a group. We asked a lot of questions. How would this look if we work together? What would be the value? How would we drive outcomes collectively? How could we improve efficiency in financial models? And really have those conversations before we sat down to, pen to paper to chart the path. So, and I think that built the right foundation. It really engaged everyone in the conversation before we went to membership outreach. So I would say we spent about 6 months in that planning phase. It was also really helpful for us. We had some outside experts who participated in the process. We had consultants who helped guide us through some of the, initial policies and contracts and that work. What was really exciting though was, when we got to membership outreach, we had a consultant who was from a different market, and he went into those conversations and was ready to, go to bat for why we needed the CIN and what the hospital was doing, as the sponsor of this. And gosh, he walked out of the first couple of conversations and said, well, I'm used to those being a lot more contentious. So I think just our model in general was built on such a collegial relationship that when it became time to ask for membership and joining, they were already really invested. And that, I think, is what made us successful from the very beginning. Shazad, I don't know if you have anything to add on that.
I think the two words that come to my mind that helped us gain traction faster and build the process robustly, the two words that come to my mind is the trust and the dialogue. So it was not a monologue that was being driven by the hospital wanting to drive this alone. It was actually a bidirectional conversation that was happening long before the participants signed off on an agreement form. And I think that was really, really foundational in getting that relationship on solid footing. And I think the other thing that has helped since that time as well has been the engagement of the office managers. So the buy-in was initially by the providers, but also by the office managers coming on board, because everybody knows it's the office managers in the primary care setting that make things happen. So getting them on board, getting their buy-in, getting their feedback was critically important in the planning and the implementation of the work.
Great. Thanks, Dr. Said. That makes a lot of sense. Switching a little bit of the conversation towards the solutions and how you looked at technology and data going forward, what was the catalyst to find a solution for the clinical integrated network, this newly formed entity, and how did you determine what type of solution you needed?
Yep, I'll take a first stab at this, and Lisa will hopefully chime in. I think the first realization was the data gap. I think we realized early on that we needed a robust data solution. We all know that what you can't improve, you can't prove. There's a quote from Edward Deming, who is the guru of quality improvement, which says, "In God we trust, everybody else needs to bring data." So I think that is a very true reflection of how the data piece is important. One of the uniqueness of our market is that a couple of our practices are still paper-based and not EMR. So we needed to sort of think about a solution that could aggregate some information from paper-based medical records as well, and be a facilitated in some way and fashion that could help those practices catch up as well as deliver on data and outcomes. We have initially sort of focused on claims data, which is mostly electronic, but that's not the only thing that we are sort of focusing on and relying upon. So integration was important. Adaptability was critically important because of these identified situations that I've sort of talked about. The other thing was that we also wanted to ensure that the providers knew that the data belonged to them and not to the hospital. So this aggregate tool was very helpful in driving that concept that they were the owners of the data and the hospital was only a facilitator.
Yeah, absolutely. And I think just to emphasize what Dr. Said was saying about we needed a solution that was adaptable and could grow with us. So we started in the beginning. We knew we had a bunch of different EMR systems, some paper-based practices that had billing data that we were going to want to feed in. And then also we were still developing what our quality program was going to look like. So, we were kind of laying all of the foundation at once. So we actually really relied on a consultant who helped us navigate the huge sea of options for what our data tool might look like and narrow it down to something that was really going to fit where we were and be able to grow with us. So, so there's a lot to consider in this piece, and especially if you're a new system, but I think, you know, it's gotten us to an exciting place where we are now.
Great. Yeah, it sounds like y'all have made some incredible strides. So, Lisa, yeah, I'm thinking about just the amount of change from a leadership perspective, you know, a technology adoption perspective, and then what I keep hearing is kind of the underlying, it's a cultural change. What if I'm a new CIN? What made you successful in all three of those factors? What could you teach me, or what can you kind of pass on to people that are starting this journey and want to reflect on kind of your successes from those three perspectives, from technology, culture, and leadership? And Dr. Saeed, too.
Yeah, absolutely. Well, I'm going to give big kudos in this particular area to our population health guru who came to us with a lot of experience in kind of this process change mapping and really getting buy-in. And so she actually really helped us lay the foundation of capacity and understanding of what population health is and what it means to be data savvy. Because I think internally and among all of our member practices, there were just a lot of gaps in knowledge. And so she really helped us lay a foundation of understanding of what population health means to us, to our network, to pediatrics, and then helped kind of build some capacity in how to do quality improvement projects in primary care, how to share best practices, how to understand the data that's in front of you. So our team's really taken the lead on the data analysis, on building dashboards that illustrate the information, decipher it into kind of easily understandable charts and actionable reports, and then really helping the office leadership take it back to their practices and apply it. Because no matter how much data we have out in the world, if we can't, you know, siphon it down to something that we can take action on, then it doesn't do us a whole lot of good. So I would really say that foundation building just of what the program is and what we're trying to accomplish has set us up for success in our early years, but really in our strategic plan as we look forward.
Yeah, I'm not sure that I can add anything more to this a pretty comprehensive response and answer that Lisa has given. I think we have reached out to other CINs as well, have learned some best practices from them. But you know, you will all realize that each place is unique and has its unique needs and wants and deliverables. So we have certainly kept that in the back of our mind. And one of our drivers has been that we have gotten some guide rails and information from the CINs, but we also needed to look beyond that to have an impact for and on our patients and families. So I think population health and the cost of care will remain an important drivers of change for both outcomes and culture for our group here.
That's great. Thank you, Dr. Saeed. So let me point towards kind of your impact and executions and the goals in this initiative. How did Philips help you in that impactability towards executing your goals?
I think the Philips tool has enabled us to have a longitudinal view of our patient population, which again addresses the population health aspect of our region, this has resulted in integration at technological levels, keeping in mind the disparity and or variations in different medical records that exist in our participating practices. And this has enabled us to develop improvement opportunities based on our quality metrics and close the gaps and help close the gaps in those metrics for our patients in the network and the providers. The tool is very adaptable and user-friendly, and definitely has kept in mind the primary care facing physician aspect of things. It's not very specialty focused yet, but is adaptable and can be sort of tool for that. But I think for our CIN, which has required heavy lifting by the PCPs and their practices in the initial phase, it's been a great value add to our members. Those practices that are not on electronic format or platform, the tool has been really helpful in helping them mature and start thinking about data analytics and actionable items based on the reports that are being delivered through the tool for their practices. And it's very customizable. So I think that's been a real benefit and help in reaching our ultimate goal of data aggregation. We also recognize that primary care physicians and their offices are very busy, and we, as Lisa earlier said, we have facilitated the translation of data into easily readable, analyzable, and actionable format with the expertise of one of our team members. Lisa, anything to add to that?
Yeah, I think it's just really, we have learned how valuable it is to have our own data tool so that we're not relying on claims data from a particular payer. It's not just hospital data. It's truly a better picture of the patients that are a part of our network. And also, I would just say that the pediatric population is harder to understand, and there are fewer sources for data that really are specific to pediatrics. So, as we look at our next steps and where we want to go, we're excited to have the integration completed so that we can start to use more of the risk stratification tools, really start to be able to tell our data story far outside of just claims or, knowing when a patient visits the ED. It's a broader look that we're getting. So thank you.
Thank you, Lisa. So we talked about cultural change, leadership change, engaging the community. We touched a little bit about solutions. I'd love to hear your take and let you explain to the audience. Have you seen any improvement? How are you measuring success, and what have you gotten kind of from this process improvement and this whole journey that you can report out?
Well, I feel like journey is our word of 2018, because we really are just kind of we're going down a journey, building our path as we go. So we've definitely had outcomes. I would say at this point, most of them are process outcomes. So as I said before, we've spent a lot of time building our dashboards and scorecards so that we can paint our picture through the data. We've spent a lot of time on integration. So again, we're not just relying on claims information, but we're integrating EMR data from all the practices that have it. We're getting some information from the hospital system, again, to just paint a more comprehensive look. But really, as we look at our co-management agreements and doing quality programs, we're able to slice the data to look specifically at the clinical measures that we want. So while we are seeing improvement in some of our HEDIS measures, as we measure that across the network, we're also able to look at and report and analyze our performance on co-management agreements and quality initiatives that fall outside of those traditional models. So it's been a lot of learning in the first year of really going live with this data, but we're excited to kind of do our year-end report and be able to show those true outcomes improvements.
Yeah, I agree, and I think one of the learnings has been, and improvements has been the recognition actually of the collaboration piece. The co-management programs that we are working on actually stemmed from the primary care physicians asking some of the specialists who are part of the team to focus on some of the low-hanging fruit in developing standardized approach to conditions, which would not only improve the quality and outcomes of patients with those conditions, but also allow more access for the specialist to see some kinds of other patients. And I was at a GI meeting last week, and we got to hear about some of these similar situations that there, and they were at the meeting, they were very intrigued to learn about some of the co-management plans that we are talking about and implementing. So there's a large interest in other health systems in developing similar approaches to improve the outcomes and care and cost of delivery of this care to their patient population. The other improvement, I think, has been the engagement of the office managers and their monthly meeting where the data is shared, and they are actually learning a lot of basics of QI and standardization of care. But equally important is that they are taking some of that information back to their offices and sharing that with their providers. So again, the word that I had used earlier on in our conversation here was the dialogue. So again, this dialogue is now happening at the front lines, which we hope will result in improved processes and outcomes and quality of care for the patients of our region.
Thank you, Dr. Saidin. In that same vein, you were talking about this journey, and we were talking about the journey that you guys are going. What would you say would be the biggest lessons learned that you can partake on our audience here?
Oh, wow. There's a whole long list of lessons learned. I think some of the lessons have been that we need to have a lot of patience when we start. And I think I would definitely share that lesson with all on the webinar. I think having a little bit of a stock of what you're starting off with, having a realization of the task, but also having a realistic goal is very important. I think critically important is the engagement piece for the providers and their office managers. I think it's been an amazingly refreshing lesson that was learned, that the more they're engaged, the more they can buy in, and the more you can have a better outcome. One of the things also is that start something and learn from it. Don't wait for perfection, because perfection is enemy of good. So small test of change, and then learning from those small tests, and then improving it, and then scaling it up is an important aspect of this. Lisa?
Yeah, I mean, I agree that patience is, I guess that's why they say patience is a virtue. It's also a hard lesson. So, we do, because we had such an engaged group of physicians and leadership, I think there was such an eagerness to tackle all of the big buckets of care that we had. And we really have tried to dial in and focus on, pilot programs, but I think some of it too has been learning the right pacing for us as we're now staffed and are able to tackle a few more things. So we've got a couple of different programs started in a couple of different offices. We've got such a great internal team that I think we're able to manage things and just try to be respectful of what we're asking of our member offices. But it's been exciting to see how our pacing has evolved in the last 6 months versus the first 6 months. So letting that happen and evolve, I think, has been a great lesson for us.
I'll also say that one of the things that has been learned is that you need a team to do this. And you may start lean with 1 or 2 people, but I think to really make an impact and keep track of things, you really do need to develop a core team of people who will do this together. And I'm a firm believer of the team mnemonic, which is together everyone achieves more. So I think that has been another one of the lessons, is that you can't do it alone. So you need to recognize and delegate as much as possible.
And we've got a great team. Not to brag,
Absolutely.
Well, I'm listening to these answers, and I'm just compelled to say congratulations. I mean, this is just such a journey, and you've made such progress and success. And but it's not time to go, okay, well, we're done and we're closed. I mean, what are you planning for the future? I mean, you've got such momentum and you've made such progress. What can you enlighten us with what the next chapter is and what the plans are?
Well, we're writing that strategic plan right now, so to be determined. Now, we absolutely are still growing in terms of membership and projects and our areas of focus. And as I kind of touched on before, I think our biggest challenge is just, defining what we want next year's priorities to be, because we have a lot of eager, engaged physicians who want to, tackle the world and make all children all better. So we're really focusing on our strategic plan for the next 2 years, keeping it, relatively short term because so much is changing in healthcare these days. So we're developing some new co-management programs, really looking for innovative ways to tackle the issues around mental health and primary care, and really excited to do some work on social determinants of health and how we can really engage and arm our member practices and being able to work with families on some of these really big, big opportunities to make a difference for the family and their kiddos.
Yeah, I agree, and we are refocusing our efforts as a hospital on community health. So I think that social determinants of health would align very nicely with our newly developed Center for Health and Children's Advocacy, which I think again allows the leverage of the CIN for the benefit of the community, and the community includes both the patients, their families, but also the providers and their offices.
Yeah, and it's just exciting. As our board chair said, when we first started looking at some of the HEDIS measures with our payer agreement, he said, I get the importance of these, but this is not why I get out of bed to be a pediatrician. It's these other programs that we're talking about that are what, excite and engage our physicians in our offices. So we're excited to keep more of those on the radar as we look into the coming years.
That's great. Thank you, guys. I want to pivot here for a second. I want to ask Mason a question, if I may, around the Philips kind of suite of tools and what they come to the table and how other CINs have implemented Philips and they've used their different technologies. So, Mason, would you kind of give us an overview of what the Philips kind of family of tools is?
Yeah, absolutely. I guess the first thing I'd like to share is just perspective. A solution is not something you unbox, plug it in the server in your hospital and flip on the value-based care button. We provide solutions that help you on a journey, and we feel like that through our experience, we know kind of those steps in that journey. It closely mirrors what we just heard on this webinar. It always starts with data, because if you ever want to get to a place that you want to measure, it's going to take discrete data. So we have solutions, normalization engines, data ingestion technologies that help you with that first step to get to where Dr. Syed said, we need a longitudinal record, right? We need to normalize that data to where you have a normalized or longitudinal record. So that's kind of the first level of a framework, and what we help people on this journey is data assets. The second is, once you have the data, then you want to look at benchmarks and insights. You want to glean kind of where you are, where is due north, and then you can start your measurement processes to see if you're actually making improvements. But that's an insight layer. That's risk scoring, analytics, UI, dashboards, reporting, a variety of different solutions at that layer. But again, this is kind of the step 2 on a journey. That takes time, aligning, we heard today, getting your physicians bought in, the community bought into what you're going to measure. But that's step 2. Step 3 is then you start to do. You start to mobilize what I would say is physician extenders, care navigators, care managers, medical assistants, people that can help with the job of engaging these patients and their caregivers. And so we have a variety of solutions that help from a task-based routing, role-based routing, dashboards that help you know which patients, which children need a certain immunization, which ones that need to be reminded about their asthma medication, et cetera, et cetera. But that's that layer, and that's definitely, I would say, step 3. You don't kind of start there. But then kind of on that journey and kind of a higher level skill is activation. We have a variety of solutions that you can enable and activate patients and caregivers in the home, kind of extend outside the boundaries of not only the hospital, but not only the primary care office, but into the home for medication reminder systems. Again, make sure they're taking their medications, remote patient monitoring. Real easy way to click and connect to either a care manager or do a virtual visit with a pediatrician. We have those solutions. So, depending on where you are in this journey, we feel like we're going to meet you where you are and then have the solutions and know-how, quite frankly, to get you to the next step. And we certainly do not subscribe to the it's all in this box, plug it in, and we'll see you later. It's definitely a journey, and we love to partner with customers like you've heard today, because it's a journey. It's one that takes passion and commitment, and it's kind of the fun part of my job.
Great. Thank you for that, Mason. We do have some audience questions that have come in. Please, if you do have any questions, let us know on the chat window or on the Q&A window as part of the GoToMeeting control panel there in front of you. So one of the questions that give me 1 second, let me aggregate some of these questions here real quick. So I have here a question, Dr. Saeed, if you don't mind answering this one. Have you become more in the pursuit of care management, aggressively kind of going after broader quality programs? Can you talk a little bit more about the co-management agreement?
Yeah, so I think if I understand the question correctly, this is, again, sort of reflecting more on the co-management programs and quality metrics embedded in the co-management program, right, Gabe?
Yes, that's correct, sir.
So and in our initial sort of rollout or first attempt at this, we have focused on one condition in the GI world, and again, as I sort of alluded to in our conversation earlier on, we focused on something that is a pain point for a lot of the pediatricians, and also allowed access to be improved for the specialists. So we definitely are developing educational tools as well as sort of contracts between the primary care physician and the patients to allow this care management piece to happen at the primary care office rather than in the specialist setting. We have a commitment by the specialist that if the patients are following the prescribed algorithm of management of this, and if they are not doing well, then their access to the specialty care will be fast-tracked and improved. And then we are going to be tracking the outcomes with measurements of ED visits, how many patients are sent back to the primary care physician, admissions to the hospital, et cetera, et cetera. So there's definitely a care management as well as a quality piece, along with some cost assessment embedded into this care management program. We are believers of QI methodology, so we believe in small test of change. So we will roll this out in one condition in one specific area, learn from it before we get more aggressive and scale it up to other scenarios and conditions. So I hope I answered that question. Lisa, you want to add anything to that?
No, I would just piggyback on that care management component. So, this is really a collaboration between the pediatricians and the specialists and the families, as Dr. Saeed alluded to. So, we're kind of arming different tools and in terms of care management, different expectations to each of those audiences. So we're trying to, really be clear in that. And again, as we pilot these in different settings, we're adapting as much as we can to each independent private practice.
From my experience, it sounds very much like a decentralized model, and it goes in line with what you've been saying about involving and empowering your community and your docs. So that totally makes sense. So I've got another question here that came in from the panel. So it's around risk. So what types of payer contracts have you negotiated for the clinically integrated network? And then how much risk are you taking on the outcomes?
So we are currently in an upside-only contract with a commercial payer that has, the opportunity to move towards a shared risk model, but really have started in that upside-only agreement. So it's a shared savings that layers on top of all of their own existing fee-for-service contracts. It's given us a great opportunity, though, I would say, to learn before we start to take on financial risk, because we've got to show some value and ability to understand the data, just getting our arms around the financial, the cost data of all the different components of care has been a big piece, because these are independent primary care practices that all have their own models for approaching care management and referrals and all of that. So I think this has been a great way for us to get into value-based care before we take on a lot of risk. But that is on the radar in the future.
Yeah, and I would agree with that. And again, the goal is to show some wins and show the return on investment for the primary care practices, because they're the heavy lifters before we take on risk. And as we have talked about, it takes a lot of maturation for this to solidify and get on board. So I think risk definitely will come in due time, but I think we need to build the foundation for a success before we take on the risk aspect of our contracts.
Thank you for that. We'll do one more question, if we may, because we have a little bit of time here. So the question that came in is, how long does this process take of starting the CIN, and what were the resources that you used to stand it up? You talked about being lean and mean at the beginning and now having more of a breadth on resources, but can you give us a sense for the resources that you used?
Well, I'm going to go ahead and say I think we're still pretty lean and mean for everything we're doing. But so we started really with an evaluation of whether or not our market might support a pediatric CIN and what that might look like, probably about 4 years ago. That took a little bit of time, and then we really, as I said, kind of convened the planning work group that eventually we transitioned into a board in our network committees. We've officially been an operating entity for about 2.5 years now, which is great. We've done a lot in that short period of time. Really started with dedication from the hospital to provide the support to get this done right in the early stages, knowing it was an investment. So they've been a catalyst and really have supported the work. Started with, this was a project on top of other duties as assigned, and then as you've seen, we grew into a team that's mostly dedicated to the network. And then I think, as I touched on before, not to hammer this point too hard, but it really was great to have some third-party resources available in the early stages, because every CIN is different depending on your market and the dynamics of, your employed versus independent physicians and all of that. So it was really valuable in the beginning to have somebody help us navigate, what might work best here.
I think it's critically important to know your market and know your area and region. That will determine how fast or how slow or what the ramp up, etc. is. We were definitely lucky from that aspect. I know of markets and cities and health systems in the country that have had multiple false starts on this. So, I think knowing your denominator is critically important, engagement is critically important, and laying the foundation right is more important than laying the foundation fast.
Thank you very much. So I'm looking at the time and just noting that we're right here at the 45-minute mark, and I'm looking. It doesn't seem like we have any more questions. So I just want to thank you, Dr. Saeed, Lisa, Gabe. Thank you, everybody that's joined the webinar. I really appreciate this. And if you have any other follow-up or questions, please let us know. I think we actually are recording this as well, so we can distribute the webinar later. But I thank you for your time. It's been a stimulating discussion, and I think we'll do part 2 one day, because this is really good. Thanks.
Thank you, everyone.